Hello, and welcome to the Remote Patient Monitoring Virtual Summit. This is Vanessa Palmer-Desiato, Project Manager at Extelligent Healthcare Media and moderator of today's session, Hybrid Nurse Models, the driving force behind hospital at home. Before moving on, I'd like to thank our sponsor, Current Health, a Best Buy Health company. Current Health, a Best Buy Health company, enables healthcare organizations to design, launch, and scale care at home across use cases, patient populations, and acuity levels. The Current Health platform combines a proprietary FDA-cleared monitoring device, a suite of third-party devices, integrated telehealth, patient engagement tools, and deep EHR integrations. Current Health is committed to successful and scalable care at home programs, providing wraparound support services to reduce provider burden and enable superior patient experiences. Today's session will begin with a presentation by our speakers. Audience members can submit questions at any time during the session using a Q&A box on the left-hand side of the screen. A recording of this session will be made available later this week. Today's session will play via your computer speakers. We do not have a dial-in for today's presentation. If you experience technical difficulties, please try refreshing your browser. For all other technical matters or difficulties, click the help icon at the bottom of the screen. Now, I'd like to introduce our speakers for today's session. Deirdre Rowley is a clinical care coordinator for the Hospital at Home program at UMass Memorial, where she has been instrumental in quickly growing the program to be one of the largest in the country. An emergency department nurse by background, Deirdre now oversees the training and management of more than a dozen hospital at home nurses. Brett Young is the manager of the Vanderbilt Hospital at Home, where he aims to transform healthcare delivery systems, optimize the care of the older adult, and empower laypersons as primary caregivers. Brett previously worked in Vanderbilt's acute care of the elderly unit and the medicine step-down unit, which became the organization's COVID-19 isolation ward in 2020. Brett also serves on the Tennessee Nurses Association's Government Affairs Committee, where, among other issues, he lobbies for full practice authority for advanced practice nurses. Finally, Sarah Joyce is the Chief Customer Officer at Current Health, a Best Buy Health company, where she is responsible for the implementation, support, and overall success of the customers and their care at home program. Sarah was formerly the Chief Client Officer at Healthcare Source, where she was responsible for client services, training, support, success, and consulting. Prior to her role at Healthcare Source, Sarah was the Vice President of Client Experience at both NantHealth and Navinet. She has also held various leadership roles in services, operations, IT, and marketing at Blue Cross and Blue Shield of Rhode Island. With that, I'd like to invite Sarah to begin today's discussion.
Thank you so much, Vanessa, and thanks for having me here today. I want to start by thanking Deirdre and Brett for joining us as well. I hope you both already know how much we at Current Health enjoy working with you both and supporting your teams and your hospital at home programs. As we're all aware, the world of RPM and care at home has changed dramatically in the last few years. Many programs that were born out of necessity from the pandemic have now become ongoing strategic priorities for health systems. One of the most exciting use cases to emerge from remote care technology is hospital at home. In hospital at home programs, we've seen remote patient monitoring being used to support high acuity care in the home, really for the first time here in the United States. So I'm very excited to speak today with Deirdre and Brett, who both have hands-on experience and front row seats to how this care model is benefiting patients and providers. So before we dive into our questions, can you both tell us a little bit about your hospital at home programs and how long they've been live? Deirdre, you want to take that first?
Sure. UMass launched our hospital at home program in August of 2021, and I'm proud to say we are climbing up on our number 500 patient. We average about 15 patients a day on service, and these are acute care patients coming out of 2 campuses. We are working originally on the CMS waiver, and fortunately, Massachusetts insurance companies have also come on board to paying for the cost of hospital home patients as their inpatients.
500 is a very impressive number, Deirdre.
Thank you.
And Brett, same question. You're welcome.
Sure. At Vanderbilt, we launched in November of 21, and we reached over our 100th patient last month in June. Our big metric we're pushing both within the organization and outside is bed days saved. And also in June, we hit the 365. So we have a year's worth of bed days saved for our adult hospital, which we're very proud of. Working with a small number of nurses, we're looking at an average daily census of around 3. We currently have the staffing to staff a 5-bed unit at the moment.
Thanks, Brett. Equally impressive. A year of bed days saved is no small feat. Okay, so it takes a lot. We know it takes a village to make a hospital at home program successful. Can you tell us a bit about the makeups of each of your teams and how you define roles, especially among your nurses? And Brett, would you mind starting this one?
Sure. So Vanderbilt, we're running our program out of the adult hospital downtown Nashville. And our makeup is we have an attending physician that works out of the emergency department. We have an intake nurse side by side screening the adult hospital. We've aligned with the rest of our inpatient traditional brick and mortar units. So closely aligned with all of our med-surg units, medical ICU, and especially the adult ED. We're pulling most of our patients from the emergency department and one of our observation units as patients flip into inpatient status. So many of these programs you can start either in the home health atmosphere or in ambulatory care, but we've chosen to design ours and align with our medicine segment in the brick and mortar hospital. So that's where we've come so far.
Great, thank you. And Deirdre, how about the makeup of your teams and your nurse roles?
Sure. We have a really robust team, multidisciplinary team. Physicians are made up of gerontologists and internal medicine physicians. We have mobile integrated health paramedics from our community that are part of our team. Care navigator nurses, they are the nurses on our team that actually do the patient acquisition. And I'd love to give a kudos to our 17 field nurses that are out doing the inpatient care right in people's homes. And that's where they're really identifying the social determinants of health. And we're really looking to close the gaps between our community and the resources that are available to them. Coming from the beginning, we started off with 2 nurses, and our team has really grown really by word of mouth because the job satisfaction has really been our highest hiring point. That nurses on our team, the majority are ED nurses that have come over, and they are back to giving the care that they wanted to since the time they came out of school. So it's been quite successful.
Amazing. And as nurses yourselves, you both have fantastic perspective on this topic. So I'd love to hear from you, or for you to share types of interactions nurses get to have with patients in hospital at home, and what you hear from your teams about why that matters to them. Deirdre, will you take that first?
Sure, I'll elaborate a little bit on what I had said before. So the majority of our nurses, like I said, are ED background with a minimal of 5 years experience as part of our team requirements. And they're actually getting in and getting to the basics of nursing again, which is something that I think is lost in the brick and mortar. Nurses do 2 one-hour visits daily in a patient's home. And not only are they taking care of the patient, but they're also involving the family and checking out what's going on in the patient's home, which is a different lens to an inpatient unit where you're not seeing the entire 360 degrees of what goes around in healthcare or in the patient's home, with good reconciliations and just seeing if they are following physician orders from when they're in the outpatient. The nurses are really saying that their job satisfaction is because they're being thanked again. They felt a lot of burnout when they were in the inpatient, especially over the past 2 years with the COVID pandemic, that they just felt like they were being pulled in 1,000 different directions and were going home not feeling like they had made a difference. And in these positions, they're being thanked again. They have such high job satisfaction right now, just to be able to meet the patients and have time with the patients and actually teach the patients what's going on with their diagnoses and helping them, helping the patients see the importance of following medical regimes.
Thanks. And Brett, anything else to add?
Yeah, we've got quite the variety in terms of patient interaction at Vanderbilt. We have the 3 nursing roles. I mentioned the intake nurse, who is really that first point of contact when we're screening patients throughout the brick and mortar hospital, really serves a nice marketing type of role and does initial assessments to ensure that the patient is socially and medically eligible for the program. Once that patient transitions to their home, the field nurse will initiate their visits, and we do 2 of those a day. And so in that particular role, it's much like the bedside nurse type of role in the traditional brick and mortar. However, as my colleague has indicated, it's quite a nurse satisfaction type of environment when you can meet someone in their home environment, really have a zoomed in approach to how one takes care of themselves. A lot of that stuff can be sort of undercover, and you got to peel it out of a patient in a traditional hospital setting. But for instance, when you're taking care of a heart failure patient and you're talking about diet and they are preparing a meal for at the home, and you can go and look in their cupboards and see how they're managing their own health, it can be very satisfying for a nurse to have that interaction. And then our big role is the virtual nurse, which is a 24/7 presence, and that's in terms of the nurse's perception of it's very innovative space and a lot of opportunity for process improvement and just creating new roles. And so we've had great experience there, especially in terms of medication safety and helping manage meds remotely and talking through and doing education with the patient via telehealth. So we've got a lot of different ways to interact with the patient, and all of our nurses cross-train into all 3 roles. So you can really know what the other hand's doing. You can have some variety in your daily practice. We've been pleased with the way we have that set up.
Thanks, Brett. And it sounds like, there's high satisfaction with nurse interactions in the home, but we know we're still in a very difficult environment for recruiting nurses. How has that recruitment experience been for your hospital at home programs, and what kinds of nurses are most successful in these programs? Brett, you want to start?
Sure. I'd have to say probably every nurse on here would say they're having challenges with recruitment. And for hospital at home in our organization, it is no different. Our organization relies heavily upon a nurse residency program for recruitment. And our program in particular, we're looking for more experienced nurses, at least 2 years of inpatient experience. And that can be remote. I'd say 10 years ago. I have 10 nurses, 8 of them are at 15 years or more experience that have done a little bit of everything in their career. So we do want, you're looking for inpatient experience. We have the same required documentation and processes and procedures as a traditional brick and mortar hospital. But it's a challenge in our market. We've really leaned into our home health colleagues at Vanderbilt Home Care Services. We share the same recruiter, for instance. So we're sharing the same recruiter across different entities, which has been helpful in terms of screening candidates, especially if they have quite a bit of experience. But it's been a challenge, but we're starting to see an uptick and be able to expand our census.
And Deirdre, how about your nurse recruitment experience?
As I'm very, very fortunate since coming onto these programs, starting the program, it's been word of mouth because of the job satisfaction. A lot of staff members now are recruiting friends to come over. So I've been pretty fortunate, been able to fill my positions pretty quickly. But I do know that with the nursing shortage, it is difficult. And I think that us offering you won't be burnt out working in this program is really a key factor into the recruitment. Our nurses, like I had said in the past, a couple of minutes ago, is 90% are ED nurses, we do have acute care nurses that are part of our team. And when building our program, we really wanted nurses that can think independently, think out of the box, because you are the only person that's in the patient's room. And if something similar to a rapid response would happen in an acute care setting, we wanted nurses that could manage their own IV lines, be able to quickly hang boluses in case of emergencies within the house. And also to think that, we bring oxygen and monitoring into the home, but an IV pole is pretty difficult to get into somebody's house and to carry in the back of a truck. So we have nurses climbing up on couches and hanging on some curtain rods. It's people that will think out of the box and get things done. And we're finding success with the ED folks here.
Amazing.
So nursing ingenuity, right?
Yeah, nurse ingenuity. We call them
right.
The nurse MacGyvers.
I love that. And sticking on your kind of nursing talent topic for a moment, how would you describe the culture of your teams delivering your hospital home programs? Deirdre, you want to take that first?
Sure. With it being so innovative, everybody's really going above and beyond in pushing this. Since this is the future of healthcare, I can't see it going anywhere else. Is to be part of the innovation for a national healthcare hybrid model. Our nurses have really embraced the care model. It's different because now everything is, vital signs are remotely monitored, and you're used to having such control at looking at monitors in the home. So it's been kind of a different experience for them. A lot are not tech savvy. Our average nurse's age is in their 40s or 50s, so not in that generation of using technology as much as a younger nurse. But the team itself has been nothing but positive in this experience, and has grown the program really great.
Awesome. Brett, could you share a little bit about the culture of your teams?
Sure. Certainly, I would describe it as largely collaborative in nature. In terms of embracing our organization's shared governance structure, it has not even been a challenge as a nursing leader to have that. Our team, really by necessity, as Deirdre mentioned, the innovation involved, but our team by necessity has been very collaborative and take part in shared decision making, because when you're launching one of these programs, it's so much process improvement and rapid cycle change, PDSAs. And so we have a very engaged team and very motivated because they see the good things about the care model. They see the improvement that it can make to our health system and in the country. So we have a really engaged group. I've been very pleased. That type of culture is very contagious when you're interviewing and bringing in new team members. They just merge right into the interstate lane. So it's been really fun.
Great, thank you, Brett. So let's shift topics a little bit. Caring for high acuity patients in their homes requires remote visibility into their condition and vital signs. What is important to look for in the RPM and other digital health technologies supporting the care model? Deirdre, will you start?
Sure. You have to trust the connectivity because you're not in these patients' homes 24/7. And we rely on Current Health, Best Buy Current Health they have a command center that actually does our 24-hour vital monitoring. And that's a different theme than what a nurse is used to doing, or what a medical team is used to doing, is relying on a third party. But the success of it has been great. You have to trust what you're using for your technology platform in these programs. And we do have some really high acuity patients that we are monitoring them 24/7. And the command center lets us know as soon as there's just something a little bit off on vital signs. And so that's been really key in keeping our program going.
Got it. And Brett, what do you think is important to look for in the technology supporting your program?
I agree with Deirdre. Connectivity is hallmark importance. But really, the big thing for us that we're looking at, remote patient monitoring in terms of vital signs. Depending on how you want to stand up your program, it's not absolutely necessary to have all the bells and whistles of continuous monitoring of heart rate, pulse ox, what have you. But what is very important is to have that communication portal. That patient is used to using a call light in the brick and mortar hospital. Getting them used to a tablet and having connectivity, consistent connectivity, and the ability to interact with a nurse face to face via video is really important. So having that straight portal is comforting to the patient, but also to the clinician. So I think that's the biggest piece, is having good connection and a good portal for communication. And the vital signs and everything is kind of gravy on the biscuit there. But those are probably the two biggest things for us.
Awesome, thank you. One of the things that our team here at Current Health spends a ton of time thinking about is how do we enable intervention with a patient at the right time, and often earlier than the patient might even notice that they're deteriorating. And to do that, we have to collect more data than we would in an in-person setting. Do you both have any real patient examples of how taking the approach of more monitoring can end up playing a critical role in a positive outcome? Brett, do you have an example that you could share?
Sure. We, of course, the patients that we're looking at, if our program did not exist, they would remain in the hospital unmonitored, right? No telemetry, continuous pulse ox, what have you. So to your point, we are adding extra monitoring in terms of vital signs. But early on, really, I think within the first month of our program, we had a scenario like this. There's a patient with stable atrial fibrillation that we had on the Current Health monitor, and they went into an asymptomatic AFib with RVR. No one would have known if the patient had stayed in the brick and mortar hospital, but we were able to catch it on our vital signs dashboard, and ended up initiating an urgent escalation of care back to the hospital. Patient did well, but that's just an instance in which, without the patient being symptomatic, would have never really known in the hospital and could have had more of an adverse outcome. But that's just a good example of sort of over monitoring someone.
Yeah, it's a great example. Thank you for sharing. And Deirdre, any patient examples that you could share?
Yeah, absolutely. Going back to what Brett had said, when patients are in the hospital, their vital signs are usually Q4 hours or Q8 hours. And with the 24-hour monitoring, we've had a couple of pickups, and one that I'd love to share with you is an early sepsis that we caught. With the Current Health skin temperatures, we saw the trend and were alerted earlier that a patient had actually spiked a fever on the overnight, and none of us had been able to catch that temperature when we were doing inpatient reads, although the patient had reported that there were fevers on the overnight. And when we did assess the patient, we did catch early sepsis. The patient started to go hypotensive from the day before, and that was all from our monitoring team letting us know that there definitely was a spike in temp for the night on the overnight shift. So that was a great good catch, that the patient did not have to go back to brick and mortar. We treated a soft sepsis right in the house, and the patient did well.
That's a great example as well. Although I would love to hear more patient stories, let's shift topics a little bit again. And since most hospital home programs are still relatively new, can you tell us a bit about what training and onboarding support you think is important to provide new nurses? Deirdre, will you start?
Sure. This is such a new care model, and to think, if you had asked me 2 years ago, did I think that these patients could be taken care of in their house, I would have told you there is absolutely no way that this can happen. And we have completely proven this differently. It's important in training to get nurses to trust the monitoring equipment, and to know that there's a safety net with it. So we keep our nurses on training for a month. They get a month's worth of training, and Current Health does come in and do hands-on training for the staff. And as we onboard new staff, we do staff teaching new staff. But we have had multiple opportunities with the current health team that they've actually come back 2 and 3 times to do some troubleshooting, um, teaches with our staff, and we're in touch with the company all the time. So it's really been a key factor yet again um, in the training purposes of our new staff. And it's important when we're onboarding the staff to provide them with that, I guess, reliability, that confidence that they can rely on the technology, and we're doing really a great job.
Yes, you are. Brett, what training and onboarding do you offer your nurses?
So we do traditionally a 6-week orientation. We have found through our experiences so far, we've found a lot of value in having training time within the brick and mortar hospital, to have some time with the established protocols and practices that our hospitals had for a long time, starting there so that the nurse, especially if they're new to the organization, can translate that into our department. Um, Having a hospital home program can at times feel siloed from the rest of the organization, providing all of this care remotely. So for us, it's been very important, especially in terms of SOPs and policy writing that you'll have to do in starting one of these up. You're either modifying pre-existing protocols in your hospital or creating entirely new ones. And so it's really important to have that new employee see both. Because this patient wants to experience a seamless transition when they come to hospital at home. So we see a lot of value in being experienced in the regular hospital, and then getting into our 3 different nursing roles. And like I mentioned before, cross training is our bread and butter, just so that everyone maintains a competency in each, and we have the availability to flex throughout the roles in terms of like unscheduled absences, of people taking vacation time. You'll see with staffing one of these programs, you have the options of sort of outsourcing some monitoring staff, but also how do you create staffing contingencies in your organization, whether that's a sister unit or the use of float pool. So we actually use float pool to help cover our virtual nurse space. It's a little bit easier to get them onboarded and autonomous, and not having to worry about them making field visits. So that's just one avenue that you can take to have some contingencies, especially when you're starting out. You're going to be a small. Deirdre said she had 2 nurses. I'm up to 10, but I'll take 10 more today if we can get them. So having those contingencies to keep your program running smoothly is really important. So you'll have to tailor the training based on both the candidate you're getting and whether or not you're doing some cross training of pre-existing hospital staff.
Got it. Thanks. And since you're both part of hugely successful hospital home programs, let's take a moment to touch on outcomes. I think we've talked about a few of these, but what are you seeing in patient outcomes within your programs? Deirdre, you want to start there?
Sure. I'd love to brag. Our HCAP scores are much higher than the brick and mortar setting. And our readmission rates, 30-day readmission rates, if we take a peek at the Medicare patients, they're at least 10% lower than a traditional brick and mortar discharge. So we're seeing that the patients are not going back. And I think it has to do with the education that they're actually getting in the home, and that we're able to keep them in their bed space as an inpatient, because there's no race to discharge when you have this patient sitting in their home. And I think that that's what goes on in a lot of institutions, is that always looking for a dispo to get the patients out, where our HCAP scores are up because we get to spend the quality time, the teaching, which is now affecting the readmission rates. And also, we pride ourselves that a lot of our patients were not doing follow-ups. They weren't ensuring that they were getting to their PCP or pulmonary appointments in a timely manner or never making them post discharge. And we are wrapping them up with a nice big bow before we discharge them home. And we're setting up all of their appointments and touching base with the primary care physicians as well as the specialty physicians to give them an update on how their hospital at home stay was and what to look for when they come to the office. So it's really turning into a continuous circle of care between admission to outpatient care, which I think is
I
going
love
to
that.
be key in the model that we're moving to nationwide.
Absolutely.
Mm-hmm.
And Brett, can you share outcomes within your program?
Sure. I think the biggest thing we really like to see is the patient experience scores that we get from our group. Our response rate is equal to that of the adult hospital. Of course, it's lower than you would want, but we're still seeing a good amount of surveys come back, and especially in terms of comments, you're seeing your areas to continue to improve. A lot of it, as Deirdre mentioned, is technology. If, you know, the older adult, we're primarily a Medicare populated unit. Um, there's some hurdles there to become comfortable with technology. So we're learning a lot as we go. But overall, the patient experience scores are high. They're best in our acute medicine units. So we're very pleased there. We hope for more folks to adopt the hospital home care model so we can get some benchmarking data from other groups. But right now, internally, we're very pleased. The other big thing is our quality, nursing sensitive quality metrics that we're looking at in all of our inpatient units. We've had a lesser incidence of falls with harm, CAUTIs, CLABSIs. So we've been very pleased there. In terms of readmissions, we're seeing right now, of course, we're a little bit smaller overall with just over 100 patients. We're seeing about the same readmission rate at the moment. But we're continuing to track our metrics every month, report them to the state and the like. But so far, it's been really good. And one thing you can really brag about for these types of things, for this to really catch on nationally, tracking this data and having it published can show our commercial insurance payers, other organizations, academic medical centers, rural health settings that can really expand the care into the community. These types of things are really important to track and continue to act upon and always improve. And so we've had a good time doing some rapid cycle change to try to prevent adverse outcomes. And so far, so good.
Yeah, amazing. Thanks for sharing that. I just have one final question for both of you. And Brett, we'll start with you on this one, but can you tell
Sure.
us what excites you about the future of hospital at home?
Well, I guess I'll piggyback off of kind of where I was going. Is what excites me is the opportunity, right? The adoption, and there's huge barriers for anyone starting this up, and it kind of starts with the regulatory barriers and stems from there. But what excites me is there are more patients, experiencing this care model throughout the country. The more data we get, the more we can prove it. The more widespread the adoption will be. We know it's a necessity to expand from the four walls of the hospital. And, every peer organization I've talked to, or if we present at conferences, everyone's fired up about this. So it's really exciting to see the growth. That's what I'm looking forward to most. And, the barriers that we experience here in Middle Tennessee are really in terms of expanding into, say, observation patients or a deeper dive into commercial payers, expanding beyond Medicare. Really, where can you go to make this bigger? We've seen a great outcome so far with primarily a Medicare population. So it's really exciting to sort of see the forecast of that aging baby boomer group that's going to need a lot of high touch care in the next decade. We've got something for them that's working so far. So just happy to see the expansion.
Awesome, thank you. And Deirdre, what excites you about the future of hospital home?
Yeah, I'm going to piggyback on Brett. I think that I had read an article last week that 6.1 million people will be over the age of maybe 65. I think that it had said in the next 2 years. So to be able to offer, this care model to more and more people and make it more available is just going to explode the growth of such a program. And it is so important that it turns into a program that is not for the wealthy, in a sense. You hear about concierge medicine and that they feel like they're the only patient that's being taken care of. And you talk to our patients that do have some health equity concerns, and they feel like they are getting concierge medicine here. And I think to be able to offer it to everybody, if they're from an urban area or from a rural area, it's just really important that everyone has equal opportunity to the healthcare that's available in this country. And that's what's really exciting to me, is that the more that this expands, the more patients are going to benefit from such programs. Um, and I can't see it doing anything but exploding, like I said. And I'm looking forward to it. And it's nice to be part of ground zero, I guess, from where it all
Yes.
begins. Yeah.
Yeah, for you both. Well, I want to thank you for spending time with me today, and thank you for sharing your thoughts, experience, perspective with all of us. And I will turn it back over to Vanessa.
Wonderful. Thank you all, and thank you for attending the session. Please note we have 2 more sessions scheduled for this virtual summit. You can see an agenda and register for these upcoming sessions by clicking Register for Upcoming Sessions under the resource list. That concludes this Remote Patient Monitoring Virtual Summit session. Special thanks to our speakers, Deirdre, Brett, Sarah, our audience, and our sponsor, Current Health. From the team at the Remote Patient Monitoring Virtual Summit and Excelled in Healthcare Media, thank you all and goodbye.